Hello, and welcome to the Feeding Pod. This is your host. I'm Brianna Millick, and I am a speech language pathologist and certified lactation counselor. I specialize in infant and medically complex feeding and primarily see patients in the home health setting, although I do have some that I see in outpatient or via telepractice. I'm also an instructor at the university level and a PhD student studying communication and information sciences. I have a huge passion for evidence-based practice and supporting information literacy in speech, language, hearing, feeding, swallowing sciences, specifically as it pertains to social media and translational research. This podcast is meant to share anything and everything related to being a pediatric feeding SLP, feeding therapist, with sprinkling in a little bit about working in academia, being a PhD student, and how to access, appraise, and implement research into clinical practice. Some episodes may contain guests, and I'm already looking forward to some of those coming up, while others might just be me rambling about something that's been on my mind. Regardless, my goal with this podcast is that you walk away not just with newfound knowledge, but with the inspiration to think critically and not be afraid of research. So, without further ado, let's get into today's episode. So, back for part 2 with Kary and Kim with Feeders and Growers. And this episode, we're going to be talking about bringing back everything to function. So, I'm going to throw it to you guys to kind of give a quick outline of what we're going to talk about today.
All right, so this is kind of a expansion of what we were talking about last in terms of chasing the why, but we wanted to talk today a little bit about function and feeding therapy and function. First of all, we wanted to talk about how we as therapists in general tend to pathologize everything. So we look at whatever kiddo we're seeing or a client that's referred to us, and we tend to nitpick all of the things that we see that we think are outside of the norm. And overall, it seems like that's really not a helpful strategy when trying to help our kiddos improve. We then want to talk about the fact that the literature is just kind of murky. There's not a lot out there to support what is normal and what's not normal and what we can do to help. We want to talk a little bit more about figuring out what's functional for the child and the family. If you listen to our last podcast with Bree, we did talk about this a little bit, but we want to deep dive a little bit more into the fact that something may not be perfect, but it still might work for a family. And then we wanted to finally kind of tie it together and talk about how we can make our feeding therapy more normal and more functional and less clinical, because it's really easy to come at feeding with your Nook brush and your Z Vibe and be really clinical, but can we make it a little bit more functional and just more developmentally appropriate for the kids that we work with?
Awesome. So kind of going into the first part. So I'm an SLP, and so the P is pathologist. And so we do talk about the fact that we pathologize everything. And when a kid comes in, it's instantly what's wrong. And so I kind of want you guys, dive into, so pathologizing everything, that's very common in our field, not just as SLPs, but as you all are speaking as OTs, and why maybe that would not be beneficial.
I think we know as OTs, and I'm sure SLPs, you would agree, there's a wide range of how humans accomplish any one task. So in any setting, not just feeding, we know that if you take 10 people, you'll likely get 10 very different ways of accomplishing the same goal. Even if they're, outwardly very similar ways of accomplishing that goal, you'll notice lots of individualized tweaks to that one task. And so when it comes to feeding and eating, I think that gets sort of pushed aside. We think, the literature says a child should be chewing like this. They should move the food here. The tongue should move exactly like this. They should, chew it sufficiently this many times. And we know that that's just not going to be consistent from person to person, and that if a child is able to functionally get an activity done, they're able to chew a food and swallow it successfully, they're able to eat enough to grow and gain weight, that is an important piece. It's maybe not the whole piece, but it definitely needs to be taken into consideration when we are doing our assessment, as much as or even more than the fact that we might notice some things that quote unquote are dysfunctional or that look different from what we were told they might look like in our feeding therapy courses.
I had a little boy referred to me once because he wasn't lateralizing his tongue well. Out of context, okay, I can see how poor tongue lateralization is going to potentially get in the way of his eating. It's potentially going to cause him to have issues with chewing. Does this child have speech concerns? I don't know. So thinking about it that way, I'm like, all right, well, that's a pathology that I need to manage. The mom brought the kiddo in. I watched him eat super resistive foods. I watched him eat soft foods. I watched him drink from a straw. I watched him run around his backyard without any sort of issue, get on swings, cross midline, you name it. There was nothing that I could look at that to me was not functional. When I stuck a nook brush in his lateral sulcus, could he perfectly lateralize to get some, like to touch the nook brush? No, he couldn't. I could dig deep as to why that function or that task was not possible for him or why he was struggling with it, but it really truly was not impacting his everyday. And his mom even asked me, I'm not really sure why I had to come to this, or like why they wanted us to see a feeding therapist. And I have to be honest with you, I kind of looked at her and I was like, yeah, I kind of agree. Like, he's gaining weight, he's eating family foods, family doesn't have a report of an issue, so I get it, this might be outside of normal that his tongue's not moving exactly like the textbooks say it's supposed to, but for this kid it works. I know we're all trying to make sure, we all want to make sure that we stay in work, right? We want to make sure that we keep our jobs and that we have clients to see, but we all know that there's way more kids that need us than we have time to see them. So if you've got one that's making things work with what they've got, if it's not broke, don't fix it.
I always like to with this sort of topic because I grew up in sports. So I always kind of refer to a normal range of ability in terms of like, so I played volleyball, and there are people who are not very good at volleyball. And there's people that like, okay, you can play it in high school. Maybe you played in college. There's the pros, there's the indoor, there's the outdoor, there's the sand. All of us though have normal motor function. Like I'm okay, so I played in high school. Yay, that's great. But I'm not at the level of someone playing in college or a professional, but I'm still in a normal range. I'm still able to do my day-to-day activities. I'm still able to function. I can do pickup volleyball with my friends if I want to. But even for people who can't, that's also okay. As long as you can get yourself from point A to point B, that's a normal range.
I love that analogy. I think that's makes it really clear that like, yeah, there's a big range of how we might go about something, how we might do something. And all within that range, we can be functional. We can be very, very normal. I think that we come upon also in the pediatric world, parents who are so anxious to make sure that their child is successful, is doing well, is thriving, that sometimes they get hyper focused on individual skills, on very discrete tasks, like they won't eat the broccoli, they can't whistle. It's like very, nitty gritty type skills or activities that when you take a step back, like Kim said, and you look at, well, are they happy? Are they eating? Are they eating other vegetables? Are they generally enjoying mealtime? Like when it comes to whistling, can they use their mouth to sing? Can they use their mouth to drink from a straw and to blow a whistle?
Does the child care that they can't whistle?
Yeah, I mean, I think that's the thing. It's like, okay, yes, these are very specific things they can't do, but it's reframing it for the parent into the human experience is that there will be certain things that I'm good at that you're not good at, or that you can do it, I can't do. And we don't need to pathologize all of those things to say, yeah, there's something wrong here. Let's dig in. Maybe there's a tongue tie. Maybe there's, a sensory difference. I think it's funny. I kind of think maybe I'm wrong, but in the speech therapy world, oftentimes it's like there's a tongue tie. That's like everyone has a tongue tie. And in the OT world, there's a sensory processing difference. Everybody has a sensory processing difference. And it's like, no, not everybody has, like there's a big wide range of what is considered a tethered oral tissue or not, and how the tongue will move and can move. And there's a big wide range of how we process sensory information that can all be normal.
Mm-hmm. Yeah, both Kary and I's husbands have restrictive lingual frenulums. And guess what? They're both successful. They eat, they drink, they talk, they kiss, They're all fine. Like, and neither of them had any sort of intervention when they were babies. And I'm sure someone could, say that my husband's snoring has to do with the fact that he didn't get that tongue tie clipped when he was, 6 months old. But at the end of the day, has it changed his life? No, it's just me nudging him in the middle of the night when he's snoring. But we tell that story a lot because there's a lot of things that people worry about, and parents have way too many things to worry about already. And when we walk in the room and we start watching a child eat, and we start nitpicking little things that that child is not doing, that's exactly by the book, I think that just increases the parents anxiety level tenfold. For one little personal story about this, my daughter came a month early, and so Carrie and I were scheduled to do this tongue tie class, or tongue and lip tie, restrictive frenulum, restrictive oral tissue course with Dr. Kary, who's a big tongue tie expert, ENT, up in Oregon, an online course. And so I was about 1 week postpartum at this point, and decided, you know what, I'm going to try to sit and listen to this webinar anyway. Big mistake. But my daughter was born with a pretty significant upper lip frenulum, very, very thick upper lip frenulum that actually causes alveolar ridging. She's got like ridging. She'll probably have space between her teeth, and a somewhat restrictive lingual frenulum. I had a lot of pain with breastfeeding initially, but to bring it back to function, everything's a-okay now. And she's a 16-pound 4.5-month old, so clearly she's just fine with her feeding. But I was watching this webinar, and they're identifying all of the things that we need to be looking at with our clients' tongues, and all of the things that could potentially go wrong if we don't assess the tongue and we don't manage the tongue. And I was bawling. And yes, this had to do a lot with my hormones. Admittedly, 1 week postpartum is a dumb time to look at anything like this, but my mom brain was just like, oh my God, there's so many things to worry about. And now I have 10 more. And my child's finally figured out how to breastfeed, and we're finally on a good trajectory. And I'm feeling so confident. And this literally sucked all of my confidence out of me, because I was looking at something that was saying that something that was functional for me is not perfect.
I think that's an important way to phrase it, Kim. I love that, because also we know that anxiety in early motherhood is associated with postpartum depression, and that can really easily exacerbate a mom who's already on that spectrum of baby blues and who's struggling and who is worried. And so I think we need to be careful about the harm that we're doing when we are pathologizing things without helping the parent understand the context, the functional context of your baby is perfect and will be fine. And yes, maybe we are preventing something down the road, but is that worth it? I think that was something that I don't know that I have a good answer for it, but early on in my career, it sort of felt like, well, it is. It's very important to make sure that your daughter doesn't end up with dental issues down the road. So we better clip that lip now. Or it's very important to make sure that, her mouth forms perfectly. So we better intervene now. But I do wonder sometimes how much we can actually perfect a child, and what is the harm done in that pursuit when we're trying to do oral stretches, for example. Like we release a tongue and then we do these oral stretches. Is there more harm because we are giving all of this negative input to the baby, and now we are breaking that bond, that loving connection, that gentle touch between parent and child by asking them to vigorously stretch the baby's tongue in a way that we know will hurt the baby. And when they cry, the parent has to squash that, has to swallow that and say, I know you're crying, but I'm going to do it anyway. So now we're also asking them not to follow their baby's lead. What's the harm done in the pursuit of perfection? And I just sometimes ask myself, at this point in my career, can we actually perfect a child? And is it worth it? Some of these, like ounce of prevention for the pound of cure, like, is this actually leading us down that road of cure? Or are we maybe curing the fact that, great, her teeth are going to grow in straighter, but we're causing a whole other side issue that is going to be problematic for her, a more sensitive mouth or some oral aversion or a rift, again, between mother and child or parent and child. So I think that's where, again, we come back to this idea of function. Yes, maybe you can help their face grow in a more symmetrical way by doing all these exercises, potentially, maybe, but is it worth it?
Yeah.
And In some situations it absolutely is. And I definitely don't want it to come off as like we're anti-intervention, because that's definitely not the case. I think we just want to delineate between the group that is okay with some different abilities versus the group that we really should be spending our time and our effort and intervention and post intervention kind of work.
No, I think it's a great point of thinking about perfect versus functional, because there's so many other qualities and aspects of life that improve child caregiver interaction, that improve just your day to day versus some of those things. And I think that also kind of goes into this next part, especially with that topic of like the literature's murky. So even when we're talking about doing something preventatively, we don't actually know if that is something that's going to help XYZ. You may do nothing and it would have XYZ would have resolved anyway. So I think that kind of goes into your all's next point of thinking about function, because the literature is few and far between in this field.
I love that. I think that's really important because you're right, especially when it comes to things like the benefits of clipping a tongue, or, you know, intervening early in a tongue tie or a other oral frenulum restriction. I think there isn't a lot of research to show that that prevention is going to functionally impact the child in a positive way later. We don't know for sure that it's going to either negatively impact speech if we don't, or that it will positively impact speech if we do. And actually the literature kind of suggests that it won't. You know, same with feeding, same with, you know, the way the structures are formed. We do know that restrictions do impact how our bodies are shaped. So I get the extrapolation there, but the literature is murky. Where the literature is incredibly solid is in the value of the parent and the child relationship, and in attachment and in connection. So we will always be following the literature if we are prioritizing that, whereas we are speculating if we are prioritizing these very discrete oral motor movements
And at the same time, you can find a clinical consensus paper from a bunch of ENTs that say clipping tongues is like has no purpose. And then you can find a clinical consensus paper from another group of ENTs that provide an exact opposite recommendation. And depending on what, I don't know how we got on the tongue tie, like that ended up being like the thing we glommed onto here, but every single thing that we treat in feeding, whether it is, I mean, another example that we were just reading literature in our learning collaborative about is ABA based feeding intervention. You can read a whole bunch of randomized control trials and literature reviews that say ABA based feeding intervention is very successful. And then you can read an entire other group of literature that says ABA causes PTSD and there's poor carryover and a whole host of other differences, and say that ABA based feeding therapy is not successful. So when the literature, basically you can find literature that pretty much is going to agree with whatever approach that you like to take. Where do we go? Let's pick something that's functional for the therapist based on their training, functional for the child, and functional for the family. Let's go there and use the available literature to support that pathway.
I think even within that as well with the literature, because you know it's we want to read more literature, and it's great to see both sides of it, but don't just read the abstracts or don't just read the title, because what you'll find in some of these articles is one group that came up with one way and another group that came with other. Well, who wrote it? What are the strategies that they advocate for just as a professional or personally? What are, you know, who is the study sponsored by? I mean, as terrible as that sounds, we really need to be careful. We really need to read into those aspects of the articles as well. And that's like just this, I'm not tied to them in any way, but that's why I like the Informed SLP, because they really look into those aspects of the articles before they're going to provide you with that information. And that bias can be very, very important, especially when the literature is so murky.
Absolutely. And it's really time consuming to do a deep dive into literature like that, and to digest it and to pick it apart and to actually think critically about what that paper, that one article is saying. I mean, even a systematic review, to think about the limitations of those in some ways. And, so I think it's time consuming, but worth it. Well worth it. It's just that, we get stuck in the day-to-day of practice, which is, you got to get things done quickly. You need to make a quick choice. You don't have a lot of time to do those things. So that's why it is really beneficial when you have therapists out there who are doing work to help bring that literature to a more understandable place to us therapists. It's great.
Definitely. So kind of going into, going from, okay, we've talked about like, let's not pathologize everything. The literature is not always there. So when we are trying to figure out what's functional for the family, maybe like, how do we go about that? How do we go about saying like, okay, this is functional for them versus maybe some of our own personal ideas of functional?
That's a great question. I think when it comes to what is functional for anybody, it's you start by asking them. So we really need to be open to having conversations with families where we say, tell us what works for you. Tell us about your day. Tell us about your week, where we lean in and we listen to parents and we listen to their fears and their concerns, but also ask about their experiences. So we have a sense of what's functional for them and what's normal for them and what they're hoping for out of this interaction. And then I think the other piece is lots of observation. So we sometimes feel very strongly in a very good way that we need to do a standardized assessment tool for every evaluation. And yes, of course, we try and aim for that as a gold standard, to have some standardized intervention tools, or excuse me, assessment tools as we're doing our evaluation. But there is so much to be learned from sitting back and using your clinical eye to just observe, to see what a typical mealtime looks like for this family, to ask them to send you videos of a typical mealtime or a typical snack so that you can observe those. I cannot tell you how often I am shocked by something that I saw that I'm like, oh, this changes the whole trajectory of my treatment plan now that I know that this is going on in mealtimes at home. So asking questions, observing, those are my two best tools for figuring out what are functional, what is functional for this family.
The other thing that makes me think of too is if we come at a family with a 3-page plan, I think you guys need to do relationship building exercises, and then you need to do oral motor activities 3 times a day, and then you need to do this sensory program before you go to the table, and then you have to talk about the food, and you need to have your child describe each food with 5 words, and then you realize that the family eats together maybe once a day and both parents are working and they come home from the office at 6, and so the amount of time they get with their children is maybe an hour, and they really want it to be positive and fun, and the nanny is not, isn't able to carry out these programs with the children. And then what's the purpose of all that work we put together, like putting that plan together? Because literally there's no way that that's going to work for that family. So can we sit back and be like, what's the number one most important thing to incorporate into this family's life to help this child with their current issue?
Yeah, I love that, Kim. I think it goes both ways. I've used that information in part to whittle my plan down, like you said, like, okay, let's take it back to what's the single most important thing. But I've also used that information, and I think this has come from many years of practice because I wouldn't have felt comfortable doing this early in my career. But I use that information also to flip it back on the parent to say, it looks like you don't have the capacity to work on some of this right now. Is this your priority? Because unfortunately, if it is, that means we're going to have to be doing some extra work here. And it seems like you don't have the time for that or the space for that in your life. I know those conversations can be challenging. And of course, there's the potential that you're going to offend somebody, you're going to get off on the wrong foot. But I think that's where our relationship with a parent and building rapport early so that they trust that your intentions are good, that you're not there to criticize them, you're on their side, but you're also there to be realistic and to help them understand, one time a week working with me isn't going to accomplish isn't going to accomplish enough. So this is going to have to be carried out every single day in home. Do you have the capacity for that? Is incredibly important. So we do need to have those conversations with families, and we do need to help them understand that functional might not be, this really complex plan that we know is necessary for this child. And so functional might be accepting that for the next 6 months, you are just going to serve quesadillas at lunch every day. And that's, that's okay, because The flip of that is that you're either going to fight with them constantly and you're going to destroy the small amount of time that you have with them, or that you're constantly berating yourself as a parent because we're asking you to do all these things that you don't have time for. So I think you can kind of flip it both ways.
This makes me think of one other thing too. Like, what can we as a therapist do to make these things functional for a family? So something that Kary and I love to do is print out scripts for families. Like, when this behavior happens at the table, this is how we want you to address it. And we're like, let's go in your house and figure out where we should tape this script so you can read it. And for some families, that is like tape it to the darn table. So literally all they have to do is look down at the table and read it to their child while they're sitting there, which seems such like a bonkers thing to do. But if that's functional and that makes that treatment strategy work for that family, go for it.
Yeah, that has been an interesting piece of learning being in primary care, because a lot of my intervention now is parent coaching through phone calls and through Zoom meetings. And I have found that when I help the parent to break it down, okay, we're going to write down these scripts. I'm going to email them to you. Can you print them out? Okay, great. Where are you going to print them out? Great. Okay, now where are we going to hang them? Sometimes you really have to break it down for parents to make it functional. And we have found so much value in very, very clear and really pared down handouts that help give the parents some clear pointers that they can use in the moment. Like 3 things for managing behaviors during a tantrum at the table, and then posting that on the wall right next to the table so that the parent can reference it when they're in the moment and feeling overwhelmed and stressed. So how do you make it functional for a busy, tired parent who does not have the training that we have? Well, you give them those skills in the moment. And so scripts and handouts that they can post next to the table that they can reference is one of those great tools that we found.
I think that's great too, because you're also serving not only as the therapist and the support for the child, but you're the advocate for the parent. So even though you're having to ask those hard questions and those tough and often uncomfortable questions of like, all right, here's what you're going to be committing to. Like, are you capable of committing to this right now, is important in order for you to advocate for that parent and to be able to in turn make it functional for them.
That's so true. I think it's, again, easy to worry that you're going to offend them, that you're going to step on their toes, but we should be having a pretty intimate relationship with this parent. Like they should trust us deeply that we are on their side, that we're there to help them and we're never judging them. So I found I rely a lot on the idea that I have a child and I'm a parent. And so I often say, I get it. I'm a mama. I know. But even if you don't have a child, just being very forward with the idea that there's no judgment. I'm not here to judge you at all. I have an idea of what I would like us to accomplish, but this is your life and your child. So you tell me what works for you. And when we establish that early, I think we really can head off that fear that we're going to offend them or that we're going to step on their toes. We can head that off at the pass, and then we can focus on the idea that we're on your side, and we get that life is hard, that, I know I'm supposed to exercise, multiple times a week. I'm a therapist, and yet most of the time I don't. So we know that we don't always follow the advice that our professionals give us. So how can I help you make that functional? Or do we just need to acknowledge that that's not going to happen for you right now, and we'll take it in a different direction? Maybe we'll focus on compensatory strategies instead of trying to remediate the problem.
This also makes me think of the concept of, again, keeping it functional, but the potential and helping kids get to the top of their potential, but then not hitting and being comfortable saying to a parent, I don't know exactly what your child's potential is, but when we get to the point where I think that they have plateaued or they've met their potential, I want to be honest with you, mom, because you could be in feeding therapy for 100 years and we're not necessarily going to get past XYZ. There are probably a selection of kids out there that are not going to be able to learn to chew. That's okay. Could we work on chewing for their entire childhood? Yes. Is that functional for that child? Potentially not. What could be functional for that child is improving their ability to feed themselves with a spoon, right? Maybe they're not going to be eating chewable family foods, but the most functional decision for that family and for that child is let's capitalize on their strengths and and improve that instead of hitting our head against the wall, continuing to try to teach a child the skill that is higher than what their potential is going to offer them.
Yeah, I think when it comes to function, we come back to the idea of independence or least restrictive environment, or like the least restrictive experience. So it may be independent self-feeding, or what can we do for this child if it's not independent self-feeding that is least restrictive, so they can advocate for themselves, they can take the lead, they can cue to us, they can participate in a meaningful way. So when function is murky, you kind of want to come back to those ideas. What would help this child to be independent, or what will put them in the least restrictive environment within this activity?
Yeah, that makes sense. And I think it kind of also ties back into that caregiver child relationship that you might be building on, where, okay, so the child, maybe their modified diet is that they, are mostly not doing chewables. But if they can self feed themselves purees and be at the table with the family and having that social experience, or at school, they're able to pack a lunch that they can self feed and they get to have that peer interaction, that's very important as well. And that goes into that quality and function of the therapeutic intervention. So kind of just this last final point, you guys had mentioned talking about, making feeding therapy more normal. And we've slightly hit on this, but I'd love to hear you guys kind of deep dive into that a little more.
So Kary and I joke a lot about how Kary loves her like Z vibe and her like white coat, and she likes to be like super like formal and fancy. And I like to show up with like my carrot stick and being like, nah, on this kid. But I think that we've found so much in working with kids, especially, we're going to see faster, more significant improvement when we use food to treat feeding. And so I think, to the best of our ability, if we are trying to teach a child to appreciate and love the family meal and sit at the table with others and eat the same foods as everyone else, sitting at a therapy table while the child is eating and you're not eating, pushing food around on your plate, is not the function that we're trying to teach that child to do. I'm sorry, I feel like that was a little convoluted in my explanation, but if we can all go back to what is our overall goal, let's do that in therapy. Our goal is to chew on food. Let's practice chewing on food in therapy. Of course, there are situations where we need our Z Vibe, our Nook brush, our chew tube, like our handy dandy tools. There are absolutely situations we need that, but how much can we use those functional things? If your goal is the family meal and your goal is for a child to eat the same foods as their family is eating, let's do therapy during the family meal. Like, let's give them things to do during the family meal to facilitate and encourage that. Just try to throw your tools out the window if you can.
I think early in my career, the Z Vibe, the Nook brush, and the white coat were a screen to hide behind a little bit. It was like, look at me, I'm a professional. I have these professional tools and I know how to do professional things with your baby. You can trust me. And so I loved those tools. I still use those tools fairly regularly in my feeding therapy practice. So no, I'm not throwing them completely out the window, but I have recognized that they were also masking the fact that I was scared. I was scared of choking. I was scared because I didn't fully understand what oral motor skills were supposed to look like or could look like. I was scared that I was going to give him a hamburger and have a hamburger story situation like Kim mentioned in the last episode. There were lots of fears. And to me, a Nook brush felt safe. It felt, like I can do this and nothing bad is going to happen. Same with a P or a Q or any of those, tools. I realize now that yes, they are safe. And oftentimes they're a fine place to start, one session or during the evaluation when you're just not sure. You don't know if the child has a tonic bite. You don't know what the child is going to do or what skills they have. Fine. You can elicit some of those skills with those tools to just give you a sense of what's going on in their mouth and what they might be capable of. But you're not going to accomplish really strong intervention that will actually change skills using those tools. You'll never get to chewing on a Nook brush. It might be a pre-prep activity that you can use to then give food, or again, it could be part of your evaluation to understand what's going on, but it's not going to get them to feeding. In the same way, I think a step down from those is, as a therapist, we tend to rely on things like puffs, veggie straws, lollipops, licorice. I mean, that was my therapy bag, early on as well, partly because they're shelf stable, which I get, but also partly because, again, that felt like that was the next safest thing. Like you're very unlikely to, choke on a puff because it will dissolve in the mouth. So great, we're going to do puffs or the veggie straws. And I get that those also have some merit. A lot of our very picky, sensitive kids won't go for the broccoli floret that you offer them. But I even have found in my therapy career especially the past 5 to 10 years, that I was underestimating myself. I was underestimating kids, especially the picky kids who are so good at spitting things out. I was so worried they were going to choke, but those kids are much, much more likely to spit out food than they are to pull it back and choke on it. So I actually had a much larger window of what I could have been offering them than I realized, because I was worried they were going to choke. So yes, choking is a real thing. Yes, we need to worry about it, but I think that we can probably give more real foods than we recognize, especially foods that don't automatically break off in the mouth. So one of the things that we often talk about is, okay, instead of a nook brush, can we use a beef or a pork rib that has most of the meat removed, all of the gristle removed? You're not going to bite through a beef rib or a pork rib, especially when you're a 1-year-old or a 2-year-old or even a 3-year-old. It would be very, very unlikely for most young children to be able to bite through those things. And they have a very similar type of input as a long, hard therapy tool. So we advocate for using things like that. We also, I know that list of foods that our long, hard sticks of food is not endless. Oftentimes we say beef rib, pork rib, lamb chop, mango pit, corn on the cob. Those are our big ones. A carrot stick, a whole thick carrot stick could be in that realm. But I think the minute I say that, it's like it triggers all the thoughts of like choking on a carrot coin and biting through it. But what we're looking for is thick, like thicker than 2 thumbs put together, the type of carrot stick that would be hard for you to put in your mouth and bite through, so that we're building tongue lateralization and we're building resistive jaw strength, but we're not looking at them actually eating that food. So if you're nervous about them choking, we tend to lean or lead with those types of foods, then come back little by little to foods that you're like, yes, they might bite into that, they might get a piece in their mouth. That's actually what we want them to do. And they need to know how to spit it out in order to safely ever learn to chew and swallow that food. So it starts with spitting that food out, chew or like bite into it, break off a piece, spit it out. So that was a very long-winded way of saying that we think there's a much wider window of being able to use real food than us therapists are maybe taking advantage of, because we are scared of choking and we're worried about looking maybe less professional if we come at it with a carrot stick than if we come at it with a Z vibe.
Yeah, no, I think that I was just
gonna type up and put a little bow on it, just to, because Kary and I also love to like go down these like rabbit holes, and that's like a whole rabbit hole that we could probably talk for another hour about. But to put a bow on it, one of the things that they teach you in OT school is like doing bicep curls is not going to teach your client to like do their laundry. And so if we're thinking about it from a feeding perspective, like we need to practice the skill, which is the function, which is the thing we're talking about. So if we want our kid to learn to bite and chew, like bite a carrot, know how much it is, like know how much they can manage in their mouth, spit out if they can't manage it, and then swallow what they can, we need to practice that skill.
No, that makes sense. And I think it also goes back to our last episode of the why. So you can do all these different interventions, and even with using some of those tools, but why? What is the reason behind why you're using it? If I have a kid who grinds teeth a lot, and so we need to use some of those tools to alleviate that sensory input that they're trying to get. I'm not teaching them to chew with it, but I'm helping them regulate, and in order to teach them a skill. And so I think just going back to the why behind it, that's just so important. So I thank you all so much. Is there anything else you want to add to this bringing back to function?
No, I just think that if you're looking for more information on this topic, I know that you have a lot of great Instagram posts that bring it back to function, which I think is maybe why, like the research and the function piece, I think we saw your Instagram work early and we're like, oh girl, she's speaking our language. She's on the same page as us. And same thing, Feeders and Growers, we have our Instagram page where we really talk a lot about this. So if you're looking for more information, I think those are 2 good places to find it.
Yeah, so thank you so much for bringing us on. It's so awesome to share our opinions and our thoughts with your community. And if anybody thinks we're crazy, reach out. We want to have the conversation because we want to learn. So please feel free to send us a DM and be like, "You're crazy with your carrot stick," and we'll be like, "All right, why? Tell me why. Let's duke it out." So yeah, thanks again, Bree. This is really awesome, and I'm glad we had this opportunity.
Definitely. Y'all are seriously amazing. And I'm sure there'll be a reason for us to be back to talk more down another rabbit hole. So
I hope so.
I love it. Thank you all. Thanks for tuning in to the Feeding Pod this week. If you enjoyed today's episode, please don't hesitate to share this podcast with your friends and colleagues and leave us a 5-star review wherever you're listening from. If you're interested in learning more about pediatric feeding and swallowing, be sure to follow Bree, me, on Instagram at Pediatric Feeding SLP. Or check out my website where you can get access to more courses and information, www.pediatricfeedingslp.com. Again, thanks for being here and listening to my ramblings, and I hope you'll keep listening. Until next time, cheers.